Health systems continue to adjust their care delivery models to reach more patients at home, and many are forging partnerships to help meet increased patient demand for these services. As we consider the entire care continuum, home medical equipment companies play such a vital role in the patient's outcome once they leave the hospital. We are the eyes and ears for the providers inside the patient's homes, and our team of highly trained professionals are standing by to help. Health system partnerships are the springboard for growth at Medical Service Company. Our collaborative approach with our partners ensures we understand their current initiatives, challenges, and opportunities so we can achieve progress together. Regular business reviews where we can share data, best practices, and create an environment of trust and transparency that all types of partnerships must be built upon. Medical Service Company greatly values our health system partnerships. We take great pride in assisting our partners in preventing avoidable readmissions, decreasing hospital length of stay, and increasing patient satisfaction. If you would like to learn more about how we can work together to achieve these results, please visit medicalserviceco.com to learn more.
Our next lecture is presented by Patricia Reni. Patricia is a respiratory clinical program manager for the McKesson Medical Surgical Extended Care Division. Before this new role, she spent the last 4.5 years as an account manager in the Northeast region for the McKesson HME segment. Prior to McKesson, she was the national account manager for the Med Group. During her tenure, Patricia consulted with various organizations to optimize best business practices within all aspects of the HME industry. She also assisted them in diversifying their revenue streams to maintain profitable margins as the industry continued to change. In addition, she was the president of P&J Consulting. In this role, Patricia specialized in compliance audits and programs, re-engineering companies to enhance efficiencies, profitability, and developing training programs centered on the staff developing, marketing, and customer satisfaction. Her efforts enable clients to expand and boost productivity in the highly competitive industry. Patricia has been a registered respiratory therapist and home care advocate in the healthcare industry for over 35 years. Her experience includes national and independent HME companies and learning successful pathways across departments to create highly profitable healthcare companies. Her lecture today is Breathe Easy, Revolutionizing Respiratory Care with Telemonitoring, Telehealth, and Virtual Training. Please submit any questions you have by using the Engage tab. These will be answered during the live Q&A portion of the lecture. To receive credit for attending, please complete and submit the evaluation at the conclusion of this session. Enjoy the presentation.
Good morning, everyone. My name is Patty Reni. I'm a registered respiratory therapist, and I'm here to discuss Breathe Easy, Revolutionizing Respiratory Care with Telemonitoring, Telehealth, and Virtual Training. The goal will be to explore innovative approaches to respiratory care for now and the future. I'm going to skip my background. You can always read it at a later date, but being ensured that I've been a respiratory therapist for over 45 years. I have worked on the home care side as well as a clinical instructor, and now I work for McKesson Medical Surgical as the clinical respiratory program manager for the United States. So today's meeting, our discussion will be overview of respiratory care challenges, such as COPD, asthma, sleep apnea, any other chronic conditions that require consistent monitoring and management. The burden on patients and healthcare systems to provide continuous care can be overwhelming. We all know that. We know that these people will come in and they're exacerbated. So we really want to look at those challenges. And by doing that, we'll introduce some solutions of telemonitoring, telehealth, and virtual training. As you know, with COVID, we sort of started to adopt telehealth and virtual training much more than we ever did, as well as even the telemonitoring. So we'll see other ways that will have challenges, as well as enhance patient outcomes to improve accessibility to care. The goal today will be to explain how these technologies transform respiratory care and how healthcare professionals can effectively integrate them into their practice. So you can see here as we talk care in place, there's a variety of interactions that we have. We have the telemedicine visit, or we could have a hospital at home. Maybe it's a smart hospital ICU referral, or it's the home visit or home monitoring. We have a lot of different options that can hopefully make our patients increase their quality of life while they are home dealing with their disease. So as we move forward, there's always a growing need for respiratory telehealth. If we look at the stats here, global rise in chronic respiratory conditions is estimated at about 65 million people suffer from moderate to severe COPD worldwide. We have an aging population, especially here in the US, of the baby boomers, leading to increased demands for home care and solutions. If you think about the baby boomers, which I have to admit, I'm one, pretty much probably 90% were all smokers at some point in their life. So how is that affecting that today? There's also challenges in traditional respiratory care. Frequent hospitalizations, visits, especially for those homebound patients. And they have difficulty in managing equipment compliance and daily respiratory function tracking. We see that over and over again, that even though they may have been trained, it's the next week comes and skilled care comes into their home and they're like, oh, I don't remember how to do this or how to take care of, even a nebulizer. And how telehealth can address these needs through continuous monitoring for the comfort of those patients at home to reduce those hospital visits as well as readmissions. So we're going to try to work with that and work with our caregivers to make sure that it's a very smooth transition for all these patients. So when we look at telemonitoring, we should always start with the definition. And the definition is the use of digital technology to monitor patients remotely. Right? We all pretty much know that. We've been seeing this for quite some time. We see this even on, nasal CPAP, where those patients will have, the Bluetooth technology or the Wi-Fi technology where their information gets communicated back and forth to their physicians as well as to their home care specialist. So we want to focus on the real-time or near real-time data. For telehealth, it's a broad term. It can encompass so many different things. So think about more remote consultation, virtual visits, things more in that vein of where these patients don't have to do a lot of leaving their home, but can get that just-in-time care to hopefully mitigate any type of situations. Why does it matter, though, for respiratory homebound patients? Well, we need to reduce the need for hospital visits. That's probably first and foremost. We need to ensure continuity of care. The minute their care breaks up, they get confused and they lose track of where they were, whether it was the process for maybe asthma management or for their COPD or on pulmonary rehab. So we want to make sure that that continuity of care stays very focused. And we want to improve their outcome through regular monitoring and timely intervention. If we only monitor for the first 30 days and then we never talk to them again, it's going to be out of sight, out of mind. So we need to have some type of constant interaction with those patients as well as those caregivers so we can have a better understanding of what goes on in their day-to-day structure of their life. With this, we're going to have integrated technology. So we're going to utilize this technology to help facilitate that communication. So we can have the monitoring of the patient health, track their outcomes, EHRs, right? How do we share this information across the different settings? And remote monitoring technologies. How do we have that real-time update so we know the patient's health status? This will help, as you can see here in this little chart, right? The smart home technology. We can go very basic to, hello, Alexa, can you answer that? I better watch out because mine probably will. Or adaptable building designs, depending on if they're in maybe an assisted living or skilled care. Or they have, an upstairs, downstairs, and they might have some type of, could be an elevator, or it could be just even those stair glides that help them up and down the stairs. Ambient assisted living, we know those structures. Information, communication technology, so that speech pathology, how do they be able to enunciate, recognize what they're saying so that we can recognize what their issues are as well, and the environmental adaptations for those home mods. So we do this, though, through telemedicine support. We need to have the access, right? If we're going to have a safe, person-centric telemedicine, they need to have access, privacies at the top, diagnostic accuracy. So again, trying to diagnose someone's issue at hand may not always work in telemedicine, right? We still might have to see them, but it could, depending on what's going on with them. Communication, the physiologic and emotional safety. They need to be able to trust us. Human factors, system design. We need to know what's going on in their home. Because if we start doing more of this telemedicine, we are not having those healthcare professionals entering the home as frequently that understands that they may have a lot of pets, or maybe they don't have someone making meals for them. So we have to make sure that we keep that integrated within that support so we can make sure that while we're monitoring them and giving them these consultations virtually, that we're also giving the correct training for the home care providers at the same time. So said a lot right there, but it really comes down to telemonitoring and respiratory care. What are we looking for? Well, we use digital and communication technology to track a patient's respiratory health and their metrics, right? We want to understand their O2 sats. If they're on CPAP bi-level, are they compliant? How are we tracking them? Are they actually using it nightly? Spirometry devices. Are they doing that spirometry, pre and post maybe breathing treatment? Are they doing some, are they using that spacer correctly so that they're taking that MDI and it's effective in its use? How is this all being handled? And what's their heart rate and respiratory rate? How are they being monitored? We all know when we walk into the doctor's office, that's one of the first things that the medical assistant does, right? We sit down, they ask, how are you okay? Anything changed over the last, 3 to 6 months or a year? And then they put on the blood pressure cuff, the pulse oximeter that takes our heart rate, respiratory rate, and our SAT. We need the same thing to happen in the home. So we need to make sure that this data from all these devices are transmitted in real time. And so that the healthcare providers can make those timely interventions. We need to make sure that if something is going south on a patient, that the skilled care is triaging that to their PCP immediately. Or in some cases, maybe calling 911 because that's really the best course of action today. So we really need to have that good understanding, but we need to make sure that the devices work both ways so that we can stay in tune with that patient. So what are the benefits? Well, for one, we know it's convenient, right? Monitoring occurs at home. They don't have to have the unnecessary trips. They don't have to go to the hospital, to the clinic. My girlfriend's mother's 95 years old. Well, they had to get the van every time she needed to go to the doctors or have her PT. Well, getting the van, getting the walker, getting the oxygen was so cumbersome that it really stressed out her mother. Now you can imagine, she's 95 years old. Being able to have done this in the home would have made life, I think, a lot simpler for her and brought down those anxiety levels. Early detection. That's huge, right? We want to decrease those readmissions. So if we can detect sooner than later that maybe they're having an exacerbation, their cough has become more productive, maybe it's changed colors. Okay, we can start them on, a regime of antibiotics sooner. We can start them, maybe they're only taking, breathing treatments, PRN. Well, maybe we move them up to QID. So we can change these things depending on what's going on. But we also want to make sure that we can increase the adherence. Patients tend to be more compliant with treatment plans when monitored consistent, right? Isn't that like anything else? Think of it, you have children. If you don't monitor how they do their homework, right, it's one and done. But if you're on top of them, they have a tendency to really stick to crossing the T's and dotting the I's. And this is what we need our patients to do while they're in their home, that they have that comfort, but that they know they're also being observed. For us, healthcare providers, improved care management. We have that continuous data. So home health is talking to the HME provider, that's talking to the PCP. We're all communicating, we're all on the same page so we can have a better outcome. Resource optimization. This constantly will reduce the need for frequent in-person visits. So now it will free up visits and resources for acute cases. This is what technology is going to do for us. We have so many people within our populations. So where we can triage some remotely will leave time for those that do need a little bit more handholding or maybe is more acute and we have to admit them. Cost effective? Absolutely. By minimizing hospitalizations and ER visits, we know for a fact that that's going to decrease the out-of-pocket cost for us, for the patients, for hospitals. It's going to make it much more affordable for everyone around. So what are the pros for telemonitoring for respiratory patients? And I have to say, I'm on the fence on some of them, right? Convenience and accessibility, absolutely. Care from home, we know that. Cost effective. Again, we will reduce the need for in-person appointments. Enhanced engagement. Yes, it can. Better management of those chronic respiratory, conditions, access to specialists, all of this is spot on. But there's also some limitations. And I feel it's important that we, as healthcare providers, understand those limitations. Number one, technology barriers. We know just going from sometimes one room in your house to another room, you might lose signal with your Wi-Fi, or all of a sudden your phone has 0 bars. Well, think of this for the elderly. So they don't know sometimes what they don't know. So sometimes they don't have a reliable internet, or the technology that they have might be a flip phone, or it's only a Kindle, and maybe it hasn't been updated for a while. So are we going to be able to communicate with that? Technical literacy. Well, heck, I know people that, are using computers all the time and don't always understand everything. So can you imagine some of the less tech savvy patients as they struggle with trying to get that equipment set up and the usage, and then also trying to, show us on a video or some type of a stream? Data concerns. We know there could be errors. We know the patients may forget or refuse to use the monitoring device regularly. I mean, I think of this sometimes with the CGMs that are out there for continuous glucose monitoring. Legal and privacy. We know HIPAA is number one. We've got to always maintain that data security. So if you're interacting with some other systems, are they all talking to each other? And do they all have that highest level of HIPAA compliance to protect that patient information that's going to be moving back and forth? What I also think is a limitation, which I don't have here, is that when we're not in the home, we don't know what's going on. In the past, we have always been, as RTs in the HME business, we were the eyes and ears for the physician as they went and got discharged. We'd walk into the home. We knew exactly if somebody was cooking. We knew how they were handling their medications. You would go into the home and you'd have this shoebox, and it was just loaded with medications. Some of them current, some not so current. And you would have to try to decipher that, right? And you'd probably be talking with home health. Sometimes the HME provider, RT, was in there before home health got in there. They're on the second floor. Well, they're using oxygen. Okay, so how are they going to get down the stairs, up the stairs? Do they have a walker? Do they have a bath bench? All these things that we assess by observing. We lose that observation touch. We have to count on the caregivers giving us this accurate information as well as the patient. I have a friend who's got her doctorate in psychology, and she's been doing telehealth since COVID. And she said that's one of her biggest concerns. Because on some of them, especially if they're not using a screen, like I have a large screen here, if they're using their phone, well, then the phone is only as big as the face. So that's all you see. So think about how you might do some of that, communication when you can't observe the surroundings behind them. So when we're trying to do that remote consultation and diagnosis, think about it. Think about the in-home RT and the virtual RT. What are they looking at? How are they communicating to primary care, or maybe to the specialist, the pulmonologist? Or how is the caregivers involved? And interestingly enough, you could have a family of 3 caregivers, and they all are on different planes. So now you've got to try to figure out who's going to be the best lead and who's going to have that follow through that you're going to be able to count on as that practitioner. So they're going to have the access, right, to all the specialists. Patients will be comfort. They're going to be better managed because they're going to have regular virtual visits if they show up. Just like they may not always show up in person, they may not always show up for the virtual visit. Oop, forgot the time. Didn't set my clocks back. So my clock says, 2:30 and it's only 1:30. So you have to understand all of those different management aspects as you start ensuring their care for that chronic respiratory disease. I found this quote and I really liked it. And it sums it up, right? Online teaching allows us to cover more content, foster a global community, and from a practical standpoint, provides a student with a closer view of our calligraphy pens than they could if they were sitting in the back of a classroom. Right? How true is that? They get to see everything firsthand, just like you are right now with these screens. But as we know, in virtual training, we have different virtual platforms. And we talked about, do they understand it? So if we have devices such as CPAP machines, bilevels, nebs, oxygen concentrators, how are they handling that? Will the virtual training be effective? It's going to reduce in-person contact, so minimize the need for hospital visits, again, especially for homebound or immune-compromised patients. Absolutely. Patients are going to be able to access training materials. So all those videos that can say, here's how you set up your nebulizer, here's how you clean your nebulizer, they're going to have those at their fingertips. The types of equipment that can be remotely trained? Well, CPAP and bilevels, they can be remotely trained. Mask fittings, could be pressure settings and usage. I'll put an asterisk on that one. Having set up the first CPAP in the state of Connecticut back in 1986, one of the things that I found with CPAP patients is that because they have not slept well, probably for years, they're not always cognizant of what's going on sometimes around them because they need some good sleep. So if you're just trying to do everything virtually, and here's the tubing, and here's how you put your mask on, they might not get it. They may get confused. Same thing with nebulizers. Pretty easy, right? Well, here's the neb cup, put the meds in, put it in your mouth, easy to clean. Portable concentrators. I, again, question sometimes portable concentrators because we need to make sure, A, they're using them for portable and not for the majority of their time, because they just will not hold up. They don't have the technology or the internal mechanism in sieve beds to be able to handle a 24-hour. But we need to make sure they understand, how they're going to use them, how they're going to get in and out of the car. Can we always do that virtually? Not sure. Maybe some people we can, maybe some we can't. So that's something that we always have to be thinking about is who's this patient and what are their limitations as we want to set these products up, this equipment up. Because without really matching that up, we could be doing the patient a disservice. So we just always need to make sure, as clinicians, let's ask a few more questions. If we have a technician that's doing the delivery of the equipment before you do the virtual training, make sure that HME technician understands what questions to ask or what to observe in the house. If it's an asthmatic and they've got 10 cats, I think that's something you might want to know. So make sure they understand, and so that you can fill in some of those blanks as they're going around and setting up some of these customers or patients, sorry. We all know the respiratory equipment not suited for virtual training is the complex. I don't think I have to break this down. We know, any type of mechanical ventilation. I might even put NIV in that. To me, it needs to be done in person. one thing that we need to remember is that mechanical ventilation is a life support. We need to make sure that the house is safe, that we know what the amperage is. We know where the circuit breakers are. The caregivers are on board. They have a great place for where are they putting the inventory, where are they going to, put that equipment. So we really do need to be there. High flow oxygen. Now, when we talk high flow oxygen, we could be talking the 6 to 15 liters, which a lot of times isn't as critical. However, if you have to tee in a couple different oxygen sources, then you want to make sure that that's going to be sound. If you're using an airbow, obviously that's a whole nother aspect. So you really want to make sure that everything there is just right. We want to know, did they put the oxygen signs? Are they in the windows? Does the fire marshal know that they're there if they did have an issue that come to the home? Are the curtains away from the concentrator so it doesn't overheat? So again, these are all things that has to go into that training, whether it's virtual or not. We still want to always make sure we're reiterating these. Trach care. Yeah, we can do some trach care training virtually, but you really can't see the wound. We need to see that ostomy. We need to see how red it is. Is there secretions? Is there, anything that is where they're having any type of secretions that have changed colors? Maybe there's an infection going on. Is it a cuff trach? Is it not a cuff trach? What's the reference numbers? I have this almost once a week. I get a phone call from either a home health nurse or a facility saying they have a trach patient coming in and they need a size 6. Well, we all know Shiley and Portex changed their reference numbers. So we really need to have more of that. So by seeing that in person, you're going to have a much better handle on making sure that the correct trach size is there, their backup trach is in the right place for emergency, that they have probably a resuscitation bag. All these things you're going to make sure is in place. Because as we do this in-person training, it's that physical interaction. We know the setup's correct. We know the patient's safety is going to be taken care of always at first measure. So we always want to make sure, what's going on in that home. If they're not home yet, maybe it's worth taking a visit. Take a look at what's going on there so that you can, we should have the in-hospital RT and the home RT always talking. This is where remote monitoring will come in helpful, because we need to have each resources. As they're getting ready to discharge, we need to know home health, we're all on the same discharge plan. And by being in that home and visiting even beforehand, we're going to understand that much better. So here's another quote that I like. If in-person training is a possibility, there's nothing like the energy exchanged and attentiveness of in-person training. Think about that. Think about when you are on a call and it's a training, could be what we're on right now. Do you have 2 screens? Are you listening to one and clearing email with another? Definitely could be. But when you're in person, you have that focus. You have that eye contact. As I say to my granddaughter, I'm watching you. Well, we know we're watching each other. So it helps. And it helps to make that person who is getting that training much more attentive, because you're adding more personal interaction for them. It's key. Think about any of the training you've attended. whether it's in person or not. Do you do aerobics at home and watch it on a screen? Are you as focused as if you were at, I don't know, LA Fitness in one of their classes? No, probably not. Some of you might, but probably the most won't be. So how do we overcome these barriers? So patient tech savviness, right? That's one of the biggest ones. Some patients, particularly elderly individuals, struggle with virtual learning. My husband is that. He was taking a driver safety course the other day, and it was painful for him. Like he kept feeling like he was doing something wrong. He wasn't. But he just doesn't have that fluidness when it comes to technology. Internet connectivity. Again, we talked about that. Rural areas could have limitations. Maybe it's not stable. Maybe they only have Wi-Fi and they don't have cellular. So what's going on there? So we need to think about these solutions. Blended approach. Think about the last two slides I was talking about. If we could blend this approach, offering a combination of in-person and virtual to assure effective learning, could that be a big help in increasing compliance to improve those outcomes? Maybe it's a pre-recorded training, right? Easy to follow, on-demand tutorials that patients can reference anytime. But maybe when you were in there in person, you help them put them maybe on a desktop so they can find them easily. If they have to go searching YouTube, they're going to get lost in whatever pops up in front of them. So make sure they have either that app or it's those links that's going to take them right to those recordings. So it's very easy, one click, and it's there. And then, of course, patient support teams. Having a dedicated remote support team available to troubleshoot is key. If we can follow up and they're saying, oh, well, I can't figure this out. Okay, let's work on this. Maybe you do have to go back out, or maybe you have a technician that's going to be going back out there. But what can we do so that they don't feel alone? We need them to feel confident that they can stay in their home and get the care they would if they were going into the emergency room, doctor visit. If it's something that's minor, training this equipment, it's so much easier if they're confident. So as we move forward with this, we need to look at the future trends. I think we're all pretty much wear, right? Some type of a watch for wearable technology. AI remote monitoring. So, artificial intelligence that will analyze the data in real time and to offset maybe and predict some of those complications. Granted, it's not totally perfect yet, but the more it gets used, maybe the better it'll become. We know we all depend on that wearable technology. I mean, the one thing that, when I get up in the morning, first thing I do is I sync my Fitbit. How was my sleep last night? And you start your day off that way. Getting more sophisticated in virtual platforms. How to do groups. We used to do this, if you remember way back when we would do a lot of CPAP setups, we would have CPAP classes. Well, we could still do that in this remote monitoring so that people could still understand that, we all have the same issues, but we can still do some of this training and not feel alone. Another thought for that. And data integration. We have so many products and programs that come out daily. So how do we enhance that interoperability between that telehealth, the monitoring device, patient records? How do we get this holistic, right, view of the patient care? But we have to have each of these pieces. You know, so often I'm being told, well, they're old, they don't use, technology. Well, I was in an airport a couple months back, and there happened to be some, elderly people. I'm going to say they're probably in their mid 80s. They were all on their cell phones, FaceTiming their grandkids. So they can do it. So it's how do we make it so they can feel part of that? And how we can get this data back to the doctor, back to that physician, back to the pulmonary rehab, so we can make sure that we're always staying on top for them. Lastly, I do have a case study. I think it's important to see that there's so many case studies out there, and I've only picked one, and this is the VA. And as we all know, they're one of the largest integrated healthcare systems, right? It was designed to support and diagnose the veterans with COPD, many of whom lived in rural areas. So we were trying to limit, right, the access to frequent in-person care. So key objectives, remote monitoring, which we've talked about. We needed to make sure, right, health metrics, SATs, respiratory rate, all the things we talked about in earlier slides. Reduce hospital admissions. That's key. That's one of the key things. But enhance patient self-management. That is important. The program was aimed to empower patients to better manage their conditions at home through the educational support and consistent monitoring. So how did it work? Patients were given pulse ox, blood pressure monitors, spirometers. They were all connected to telemonitoring. They had daily check-ins. It was either going to be through an app or a call center, depending on their comfort with technology. And then it was reviewed by the care team. So RTs, nurses, and physicians. They had an alert system. So certain thresholds, low O2 sat, rapid respiratory rate, right? If they got hit, an alert would trigger. Great. Exacerbation could adjust their treatment or receive medication before full blown flare-up occurred. That's also the key thing. Catch them at the beginning of it, at the onset, not when they're already struggling to get a breath in. And then virtual consultations. In addition to monitoring, patients had regular virtual consultations with their healthcare providers, where they could review the data, symptoms, adjust treatment plans. For the vets living in the rural or underserved areas, it ensured continuity of care without frequent travel. So that, again, was another key part of their program. Outcomes. Reduce hospitalizations by 40%. That alone, to me, is a check win, right? Improve patient outcomes. Patients who monitored through telemonitoring experienced fewer severe exacerbations. Didn't say they didn't get exacerbations, but they were fewer severe. Early intervention, whether it was medication adjustments, increase O2, whatever we had to do to stabilize their conditions. Patient satisfaction was up by 90% because they felt like they were managing their condition. Cost savings. The VA reported a significant cost savings due to the decrease of hospital admissions and ER by about 10 grand per patient. So think of that over the course. And the program's component was a critical success. Patients were educated on proper breathing techniques, inhaler use, lifestyle adjustments, which help them better manage their condition. Again, people didn't have to wait to have that travel. So you could talk to more people in a day. And you could do that high touch, even though we're doing it virtually. So think about this. In conclusion, telemonitoring and telehealth, right, revolutionizes respiratory care by providing continuous, real-time data and access to healthcare professionals. Virtual training will ensure patients can manage their respiratory equipment safely and effectively, even from home. I'll add there, don't forget about the blended approach, because blended to me is still going to be one of those key factors in making it a complete success. Call to action is encourage all our healthcare professionals to adopt telemonitoring and virtual training where feasible. Again, it's not going to fit everyone. We need to stay current with telehealth tools, practices, support respiratory homebound patients. I mean, we think about this with CPAP. CPAP uses the majority of monitoring. Mask fitting, Sovasage is one, right? They can do an AI mask fitting in their home. And there's others out there. So know that there's different tools that you could use. With that technology advancements and increased access, we're going to see respiratory care will continue to evolve, making it easier for patients to breathe easy. With that, I will give you questions. And on behalf of McKesson Medical Surgical and Medical Service Company, thank you so much for allowing me the opportunity to meet with you. Have a great day.
Patty, incredible stuff. Thanks so much for being with us. I appreciate your time and the effort that went into this presentation. You know, as I said at the first Q&A, you know, really the forefront of the healthcare industry, some of our early presentations, obviously, you know, monitoring remotely, telehealth, telecommunications. You know, we'll hear a little bit more about that type of stuff with our keynote speaker later today. So very hot topic. So thanks for touching on it, and we appreciate your time.
Thank you so much. I really appreciate the opportunity. It's always great fun with you folks.
We love it. We'll jump into the Q&A. I don't want to, leave anybody short on their great questions that sent in. We got a lot of engagement in your presentation, so I want to try to get through as many as we can. One of the questions I wanted to start off with that, almost bundles some of the questions into one is, from your recommendations, how do you drive engagement in some of these more telehealth type of office visits? I think we're all victims of not being 100% honest with our clinicians, even when we're in the office. So when you have a virtual appointment, how do you drive that engagement with them to give you the full scope of what's going on with their health and what's going on at home?
That's such a great question. I wish I had all the answers for that one. I mentioned about my friend who does telehealth from a psychology perspective. And she's got her doctorate in psychology. And she's, when she was doing this, I'm like, how are you getting their attentiveness, right? How are you making sure that you're getting that feedback that you need, especially from when you're in therapy, right? Mm-hmm. Same difference with our patients. It's getting them so that they're connecting, finding out what really works for them. We don't ask sometimes enough questions. We just assume they can handle the screen. So I think it's figuring out what's good for them. And again, they're caregivers or lack thereof or whatever. Mm-hmm. An example is I had a hospice, I think it was a hospice facility. It was a hospice or regular facility, contact me because they were frustrated. They have a bi-level patient. And the patient was being trained by a therapist in California. They were in Texas. So, which is fine, right? It's telemonitoring. However, this was an elderly patient on bi-level, and the only thing they had was a phone. So tell me how you teach using a phone if that's all they can see. You're just seeing the guy's face.
Mm-hmm.
Are we getting that? So it's saying, okay, what do we have to do? And that's why I always say the blended approach.
Mm-hmm.
Do they have another? Can they get a laptop for that time being?
Mm-hmm.
What are those options? So I think it just comes down to asking more questions and then holding the attention of that patient and
Mm-hmm.
saying, help me understand what's bugging you. What do you have
Sure.
issues with or whatever? But it's not an easy time right now.
Mm-hmm.
As we're moving through the end of the baby boomers, right? As we're getting into that, yep, we're more a little bit tech savvy.
Mm-hmm.
When it's the next generation, that's not going to be an issue. They live their life on computers.
Mm-hmm.
So they're going to have that. So it's this gap time. This is
Mm-hmm.
what we have to work on is the people that are, we'll say 60 and above, that's where we might have a gap.
Mm-hmm.
And so how do we meet them? So it didn't really answer your question probably, but it's understanding the audience and what's the main goal. If we're just going to talk, then not a big deal. But if I have to demonstrate, I need a better platform.
Sure. And I don't think there is a right answer to that question, right? So tough question to answer, but definitely something I think a lot of people out there are dealing with right now and trying to struggle to find their own solutions to those. I know in the DME world, right, we struggle with trying to find solutions to that question every single day. So another question that we had was, in an environment that is short-staffed, which I think a lot of people out there feel in the healthcare world, when you are short-staffed, what sort of approach should you take or what emphasis should you put on the virtual type of monitoring or virtual setting?
Well, I think the first thing is since we are short staffed, let's get rid of the tasks that the RTs are doing that they don't need to be doing. How many phone calls are they answering because somebody needs a reorder or something like that, or they're doing inventory resupply, and we can automate that. We can get people doing that, but I think what we need to do is sorry, I lost my train of thought on that one. Is
You're fine.
is getting okay? I'm going to step back a second. Did I tell you I was a baby boomer? No. Run that last part of that question again.
So it's just, I think really what the question is trying to dive at is, when you are in some of these short-staffed offices and you are doing some virtual care, where is the line in the sand for what focus or emphasis you should be putting on the virtual setting? When you are short-staffed, should you be focusing more so on the virtual, or should you say, we really don't have the capacity to do this monitoring? Should we be driving more patients into the office at this time period?
Well, I think in that looking at it from that perspective, the answer is yes on both. I still think, and I was reading the chat as the presentation was going, and what I'm seeing is there was a lot of correspondence of RTs wishing the CPAP classes came back. Why couldn't they? Isn't it better to have them in your office as a group? It goes back to the old awake stages, right? When we used to have the awake groups and things like that. But having them there, then you could say, okay, here's step one. And you might be meeting with 10 people. You're not talking, you're talking overall diagnosis. You're not one-on-one personal, but you're getting all that training. And then from there, you can show them how to be remote. Here's what we'll do on our next one, but you're taking care of the lack of staff. But if you also need to get that, patient or two patients or three patients, maybe something different. Maybe it's a different, interface. Whatever it is, you can at least get it right there versus have to come back or send somebody else back. Now you're not being efficient, right? So that's where I think, as I go through and I meet with a lot of our customers, I ask the RTs, what's your pain point? And they're like, I just can't be a clinician. I'm being everything but, So I think we need to get them to be the clinician so that they can focus and move forward with whatever mode's going to work for that group of patients, for that patient, whatever that case may be.
Gotcha. Thanks for diving into it. Definitely some challenging answers. It's a very gray area in the industry of, when do you have a patient in? You can run numbers for success rates, but sometimes, results don't tell the whole tale for the individual patient experience. So very, very challenging. I know one thing that we have some difficulties with in the remote or the telehealth setting is overwhelming patients with information. And I don't know if there is a correct answer out there for exactly what the best pieces are to go over with a patient. So when you are, let's call it a brand new sleep patient, when you're seeing them for the first time in a virtual setting, what, in your opinion, are some of the items that you should really focus on to drive home to make sure that they're not getting overwhelmed and missing out on those pieces that might be most impactful to their therapy?
You should be going over everything you would if you were in person. You can't dummy it down. You can't say, oh, I only have to go over this. Truthfully, I would like to have a tour of their house. That's an eye opener right there. Where are they putting their CPAP machine? Are they sleeping in a recliner versus in a bed? This is the stuff that when you can see it and you're just talking, but you're observing, it's like, here's another question I need to ask them. But when you're closed circuit, like what you and I are right now, it's hard to say. So I think having a conversation with the patient first, saying, here's what we're going to do when we're remote monitoring. I'm going to ask you to take me a tour of your house. We're going to go through this. I want, do you have any pets? We're just going to be talking about that stuff. Maybe you give them, just a heads up so they know what to expect, because most of them don't know what to expect. But if you leave stuff out in that beginning, consider yourself getting more phone calls. And those phone calls are going to be at 10 p.m. at night. And now you just blew the reimbursement that you're getting.
Yeah,
I mean, just being realistic. It's, reimbursement for CPAP is slim. So we do need to be, spot on. But if you shortcut, it's only going to come back to haunt you.
Sure. No, and I appreciate you diving into the phone call portion. Trust me, we understand where you were coming from with that comment. We deal with it on a daily, or I'm sure for our revenue cycle team watching out there, on a moment basis. Every single moment we seem to have a patient call in that we hoped that could have been satisfied on the front end. So we only have a couple minutes left, and the last question I want to dive into is, I really enjoyed the portion of your presentation where you talked about how do we continue to monitor those patients beyond that first 90 days. I know it's one thing that our company has designed a new team. We do a lot of focus on it, kind of that continued compliance, if you will. From your perspective as a clinician, what does that look like to you in terms of following up with those patients and trying to change that, that 50% number of patients that utilize their device? There's only 50% of patients that use it after the first 13 months. What is it that clinicians, companies, anybody can do to increase that percentage?
As I'm sitting here and I'm thinking about it, it's high touch. I think, and if I go back to the beginning of, even your organization, which, I've known through the years, it was high touch. That personal interaction where the patient felt comfortable with, if you as a clinician said XYZ, they're going to say, okay. And when we can't do that consistently, and they don't have faith that we're going to be there, that's what I think ends up decreasing and mitigating our compliance. So often most people, they're spot on until 90 days. 90 days hit, they're like, all I have to do is find out if they need resupply. Well, no, we still need to know how many hours a night are you sleeping? What are you having? Are they really changing? When I get people say to me, oh, well, they don't need, the patient said they didn't need this supply, and this supply. Really? So did you look at that mask? Can you show it to you online? Maybe. So I think it's just letting them know that we're going to be there and hold them accountable.
Wonderful. Hey, I love the touch comment. I think that being involved in patients' life is important for the clinician as well as the medical device company, whomever is in that circle of care for that patient, making sure that they're in touch, even if they end up telling you, please stop calling me, I don't want to hear from you anymore, right? You want to get to that point.
Exactly.
So Patty, we are at time. Thank you so much again. I know a lot of work and effort goes into not only being part of this forum today, but to caring for your patients. So thank you what you did for us today. Thank you what you do for your patients. We really appreciate your time and efforts. Thank you so much.
Thank you. Appreciate you both.
And for everybody watching out there, quick public service announcement. The presentations from today's session will be uploaded and available later today through this feed loop portal. If you missed a survey pop-up, you can access it this afternoon where it will appear after a brief 2-minute delay. Thank you for your participation. If anybody has any questions, please put them in the chat. Patty, again, thank you so much. Have a wonderful weekend.
You too. Happy Thanksgiving.
Happy Thanksgiving. Thank you.
Bye-bye.